Welcome to Exploring Health with Cleveland Clinic London. I'm your host, Kash Akhtar, and I'm a consultant orthopaedic knee surgeon. Our special guests today are Ms. Kalpana Devalia, a consultant bariatric surgeon, and Professor Barbara McGowan, who is a consultant in diabetes and endocrinology. Today, we're discussing a topic that affects millions of people around the world: weight loss and weight management. Whether you're on your own weight loss journey, or whether you're curious about the science and the treatment options possible, then this is the podcast for you. So let's jump right in. We all know that obesity is a growing epidemic increasingly around the globe, but what kind of impact does it have on public health? Could you kick us off?
Thanks, Kash. So you're absolutely right that we have an epidemic of obesity, and the prevalence has been significantly rising over the last few decades. And if you take the UK, for example, it only affects nearly a third of the population that lives in the UK. And with it, it affects our health because obesity is associated with at least 200 complications of obesity, which we can broadly divide into three categories: so metabolic, mechanical, and mental health. So if we look at the metabolic complications, diseases such as type 2 diabetes, much higher prevalence of type 2 diabetes, cardiovascular disease, hypertension, hyperlipidemia. So these are all associated with increased rise in obesity. But then also mechanical issues, osteoarthritis, back pain, which can also affect our ability to work and quality of life, obstructive sleep apnea. Many people are sleeping with CPAP machines at night to help their breathing. And then the impact on mental health, that I'm sure we'll discuss during this podcast, anxiety and depression associated with obesity. Of course, we mustn't forget the high prevalence of cancer. There are many cancers, the risk of many cancers associated with obesity. And of course, the prevalence of many of these cancers has also been increasing over the last few decades.
It was interesting. I did a podcast with Paul Jarman about dementia, and he mentioned that certain times of dementia are massively increased with obesity as well.
I think that's probably right. I think the evidence around dementia is probably just emerging. That it's not as well established, I think, as some of the other fields, in certainly the metabolic, cardiometabolic fields. But I think there is some evidence to suggest that is the case. And indeed, some of the pharmacotherapies, the new pharmacotherapies for obesity, may also be helpful in areas such as dementia. Although we're sort of waiting for the data to come out for that.
Thank you. And Kalpana, is there anything you'd like to add to that?
Yeah, I think everything that Barbara mentioned, it affects every single organ of the body in a bad way. And overall, it reduces the life expectancy by almost a decade. And that's really serious health implication. It's a public health issue, and there is no single country in the world which is not affected by this epidemic, and it requires attention. And I think it has a serious economic impact as well, as it's projected half of the world population will be overweight or obese in just over a decade, actually. And that will have a serious economic impact on the cost of treating the complications of obesity that are going to arise, and reduced life expectancy.
And once upon a time it was considered a first world disease, but now we're seeing it more and more in emerging countries as well, aren't we?
Yeah, it's terrible. I was just at the bariatric conference at the Asia Pacific chapter in Mumbai last week, and it's shocking. I mean, you see malnutrition and underweight and obesity in the same country, and it is. The huge health disparities. And I think the main reason for that is the westernization of the lifestyle changes that have taken place. And in addition, I mean, the economic situation hasn't really improved. So you're seeing a double whammy effect.
Yeah, and certainly increased globalization has not helped.
That's correct.
The thing is, it seems like it should be simple: eat less, move more, but clearly it's not that straightforward. There's often a misconception that obesity is purely a lifestyle choice. But let's set the record straight. Why is weight management so difficult? What makes obesity a disease rather than what some may unjustly term a personal failing?
That's a really good question, Kash, and a very important question. So obesity is a disease for many reasons. There are clear genetic factors that affect somebody's weight. There are those people that can eat whatever they like. They've got their genetic makeup that allows them to do that. And those that are obviously predisposed to gaining weight when they're exposed to an environment where there is plenty of food, like we have today.
The obesogenic environment.
The obesogenic environment, absolutely. So depending on your genetic makeup, different people react differently to the same environment. But there are also biological factors. We have a very complex biological system that controls appetite. There are gut hormones that inform our brain as to how hungry or how full we are. And of course, resistance to those signals can affect how we, whether we gain weight or lose weight. It is a very complex system that we operate in, but there are clearly genetic, biological, and environmental factors that determine what our weight is and why obesity is a disease.
And can we just talk about some of these biological and hormonal factors? Because obviously that's where a lot of the treatments are heading now.
Mm-hmm.
The hormones like ghrelin, leptin are the things you hear about nowadays. How do they play a role in weight gain and appetite reduction?
I guess there are broadly two different types of hormones. If we talk about leptin, for example, leptin is a hormone produced by adipose tissue, and it is a signal of long-term adiposity. So the more adipose tissue we have, the more leptin we produce, and leptin does signal to the brain and switches off appetite. It's basically saying you've got plenty of fat, you should eat less, but it's a long-term regulator of appetite. And then we have gut hormones that change sort of minute to minute, second to second. So for example, just before lunch, our ghrelin level, that's our hormone level, will be high. They tell the brain that we're hungry.
Right.
So ghrelin is produced by the stomach. And like I said, levels are high before lunch. And then after we eat, there is a suppression of ghrelin levels. Similarly, we have other hormones, satiety hormones, like GLP-1. I think most people have heard about GLP-1.
They have now,
secreted from the gut. And other hormones, oxyntomodulin, PYY, amylin secreted from the pancreas. And many of these hormones act as satiety hormones. They are released after we eat to tell our brain that we are full. And some of these hormones have been taken forward in clinical trials, of course, or long-acting versions of these hormones. We call them analogs, GLP-1 analogs, and they've been sort of translated, I guess, into new pharmacotherapies for the treatment of obesity.
And, one of the reasons we're talking today is because of the new GLP-1 agonists.
Mm-hmm.
Well, I call them agonists, but you're the expert. Analogs, is that what I should call them?
Well, they are GLP agonists. Of course, they act as the GLP-1 receptor as an agonist. They work on the receptor, but they are analogs because they're slightly different from the GLP-1 molecule. Just a few changes in amino acids, but most of them will have a long-chain fatty acids attached to them, which basically allows them to bind to this protein called albumin in the blood and allows them to basically be around for at least a week. So the half-life is long, and therefore they're weekly injections.
Perfect. We will come back to those. Mm-hmm. I was just being careful of my terminology. I'm an orthopaedic surgeon, and talking to you guys, I feel like I'm being examined for the FRCP. Yeah. So I need to make sure that I'm spot on.
You're good.
So I want to understand how much weight gain and weight loss is driven by biology versus lifestyle choices, socioeconomics. Can you give me an idea?
I think obesity is a complex. It's complex, multifactorial chronic disease. As we already discussed, there are so many factors playing into it. For years, we've been listening to this mantra of eat less, move more, but the science is telling us different. Because it's not just about that energy balance, it's sort of by eating, but there's so many other factors playing into it. Obviously, it's true that diet and exercise play a significant role, but because there are so many other factors involved which we have very little control over, it's difficult to sort of nail it down to one particular factor causing, because people can be predisposed genetically to become obese. And in addition to that, the environmental factors play a huge role.
And it's interesting that you mentioned the environmental factors. My NHS practice was at the Royal London, and there's kind of Whitechapel as a chicken mile. And and the thing is that if you've got a school kid who's at home whose parents are both working 2 or 3 jobs, and for £1.99 they can get chicken and chips, then that's actually a lot of calories and satiety in one hit. We're actually being able to, have fresh fruit, salmon, meat, vegetables, to cook it. There's so many more factors to it from the socioeconomic point of view.
Totally, because I think it's well known that the incidence or prevalence of obesity is more in areas of food deserts where there is no access to healthy food, and especially the prevalence is more in places where there are more of these fast food, easy access food places, and especially in the north of the country. If you're talking about the UK, the prevalence is higher compared to where we are here in London.
The other thing that's quite interesting, another thing you touched on, Kalpana, was exercise and weight loss. I often have conversations with patients who have knee arthritis, with knee pain. And I say, we talk about the 3 stages of managing knee arthritis. And one of the early stages is just weight management. I'm always very careful to say weight management as opposed to weight loss.
Absolutely.
But the thing is, and they say, well, the reason I'm overweight is because I can't exercise because of my knees. And yet, exercise is a very small part of weight loss and weight management. How do you frame that conversation? Because you must have that conversation regularly.
Yeah, absolutely. I think it's extremely important, the energy intake, what's going in the body compared to how much exercise can help with the weight loss. Because, if somebody is on a very energy-dense diet, which is not nutrient-dense, but a very high energy-dense diet, and there is very little activity, and that could be due to a number of reasons, as we mentioned, then it's going to be difficult for them to lose any weight, and it's all going to be accumulating. And I think the biggest factor would be contributing to weight gain is the insulin resistance developing in these patients, and that's why all the energy is being stored in all these fat cells and causing the weight gain. So exercise does play a role, but it's extremely important from the energy coming in to
the food
control
intake.
the food
intake.
Caloric intake in the equation is highly important. But sedentary lifestyle contributes to weight gain because...
Barbara, jump in.
Yeah, just picking up on that. I think you're not going to lose weight by exercising. You have to do a crazy amount of exercise.
You can't outrun a bad diet.
No, exactly. So I think, but of course, physical activity is important for good health, for your heart. And also, when we do think about weight loss interventions, which we're going to get to, it's very important to protect your lean muscle mass, and therefore physical activity will help to do that. But you're absolutely right that it's when people say I'm not losing weight because I'm not exercising, actually, it's unlikely to be the issue. Ultimately, it is about food intake, and if we are not moving very much, let's say because you've got osteoarthritis or whatever, we just don't need that much in terms of calories going in, and we need to try and think about the calories coming in and the quality of those calories. But of course, that's very difficult, and that there's the challenge. People feel hungry and they eat. Or stressed, or there are so many factors driving.
So many reasons. And I must say, I find that conversation quite challenging. But then I will often say to the patient, look, if you go on a treadmill and you run for 10 kilometers an hour, which is a decent pace, for 30 minutes, you'll lose maybe you'll burn 230, 240 calories, which is less than a Mars bar.
Correct.
Don't eat the Mars bar. And all of a sudden you're ahead of the game. And then if you do some exercise on top of that, you may then become to the point where you are then burning more than you're taking in. And of course, you say the mental health benefits of exercise, bone health, joint health, putting off osteoporosis, maintaining lean muscle, those are vital, aren't they?
Absolutely. And the one thing to add is after weight loss, physical activity can help to maintain weight. That's the one thing I would say. So very good for weight maintenance.
Barbara, when it comes to managing obesity, as an endocrinologist, how do you support patients before considering medication or surgery?
Lifestyle intervention is always the very first step for any weight management intervention. So we look at their diet, we look at their physical activity, we look at the stressors in their lives. So it's really, really important that whatever the intervention, i.e. whether pharmacotherapy or bariatric surgery, that the lifestyle side of things is addressed first and foremost, because I think all of those other interventions would be much more successful if all the facets around, a healthy diet, good sleep, stress are also addressed. And most people will have tried that, of course. I guess by the time they come and see us or Kalpana, they're ready for the next step. But it's always really, really important to ensure that they know what a healthy diet looks like.
And it's interesting you mentioned sleep, because that's not a thing you normally hear when it comes, you normally hear about exercise, burn more, eat less. Sleep's not a thing that often comes up in this conversation. What's the impact of sleep?
It's really important to have good quality sleep. If you don't, it can have an effect on cortisol levels, metabolism, and metabolic health, really. So I think it's definitely part of the equation. And if you feel well rested, you also have more energy. You can then do physical activity. If you don't sleep well, or if you have sleep apnea, for example, you wake up feeling just tired, essentially, and then it affects your well-being, can affect your mental health if you feel tired all the time. So, a good night's sleep is priceless.
And so that can trigger hormonal changes that may actually lead to weight gain.
Yes, absolutely.
What's your approach to helping patients understand that obesity is a chronic disease and it's not just about willpower?
So the conversation that I have with them is, first of all, trying to not make them feel guilty, because they'll all come to you and say, oh, it's my fault. It's my fault. And actually I say to them, no, it's not your fault. Your weight is not your fault. And then I do try and explain exactly what I said before, that there are genetic, biological, environmental factors as to why our weight is what it is. So I try to empower them to make them understand that. And that's really helpful. When they understand that it's not their fault, they do feel empowered, actually, because it takes away a lot of the guilt that they have been feeling for many, many years. And sometimes using the pharmacotherapy explanation can help, because we now do have hormonal options that work, that switch off appetite. And now they can understand that actually you're right. It is probably my hormones. Perhaps I don't get to that satiety level like somebody else who's thinner, but I need that hormone to help me. So trying to conceptualize it, with these new gut hormone therapies can also help them to understand obesity as a disease, because we now have a treatment.
And actually, there's a thing that struck me the other day that really was a light bulb moment for me, which is that since these new medications have come on board, people lose weight quite dramatically, and they're not exercising anymore, which shows that exercise is not part of the equation, really.
Yeah, no, you're right. I mean, the medication is a great tool, okay? It does stop you from being hungry, essentially. So people come to us and they say, all my food noises have gone away. Yeah. And when they eat, they get full very quickly. And these are the same people that were struggling. So suddenly they're not struggling anymore. Yeah. But by losing weight and by improving several of the complications, including knee pain and other hip pains, they are actually more mobile and they feel happier. And they then start exercising and get on with their lives and go back to work. And so it has, positive impact on so many things.
So many ways. You're obviously a specialist working in a hospital setting. Are there any baseline tests that you do or body composition analyses before you start treatments?
Well, if you have the possibility to do so, absolutely. It's always good to see where the fat is, especially looking at the visceral fat, which is the one that causes metabolic health, type 2 diabetes, insulin resistance. So if we have access to the scanners, which does that, that's very useful.
Like a DEXA scan?
Yeah. Well, a DEXA scan is a more laborious way to measure fat. There are some machines which give you sophisticated calculations with regards to body composition, which is helpful at baseline. I always like to do just routine bloods, obviously at the very minimum, to check whether one has prediabetes or type 2 diabetes, for example. There's a lot of it is not it's not picked up unless you have a blood test, for example.
And so forgive me, there you're talking about fasting glucose, HbA1c?
No, just HbA1c. We don't need the fasting glucose. HbA1c is a very good marker. It's an average of your sugar over the last three months, so that's a good one. Liver test, for example, lots of patients have fatty liver disease, which they don't know anything about. And again, fatty liver can progress to fibrosis and cirrhosis. And that's something that it's worth picking up at baseline as well. Nutritional status. Lots of patients have a surplus of macronutrients, but actually they're actually deficient in lots of good stuff like vitamin B12, folate, everybody's deficient in vitamin D, but also iron, So picking up these things at baseline is the right thing to do. It's not essential for starting, for example, the pharmacotherapies, because a lot of these medications are not renally excreted, i.e. they're not excreted by the kidneys, they're not excreted by the liver. So it's not a contraindication as such. But to have a good, healthy metabolic profile at baseline, I think is helpful.
Do thyroid function, would that come into it?
Yeah, I mean, thyroid function tests, again, if you had a thyroid function test done probably in the last year, you probably don't need another one unless there are clear symptoms of an underactive thyroid, which would warrant doing a baseline test. So, I mean, in my practice, I do actually do thyroid. I check a hormonal profile. I do a sort of, I have a holistic approach to obesity management.
Perfect, thank you. And Kalpana, can I ask? Well, whilst we're talking about interventions that are not physical interventions, I want to ask you about intermittent fasting. It's something that I've been doing for the past year or so, and I found it quite powerful. What are your thoughts on that?
I totally agree with you that personally, I find it very, very empowering, and I think, but it's not for everyone. I have tried it. I don't follow it every day, but I totally get it that, it does play a significant role, but I don't think we're quite there in prescribing patients on intermittent fasting, because it has to be a personal choice. And not everybody can actually follow it. And I think it would be difficult to assess on how their body reacts unless and until we have a regular continuous glucose monitor for assessing on how people respond to different kind of foods and whether the fluctuations in their sugar levels are very dramatic, and whether the role of intermittent fasting is sort of in stabilizing those levels.
It's interesting because it has definitely exploded in popularity. You hear about it all the time. Lots of people are doing it. The other thing you hear about increasingly are now people using continuous glucose monitoring who don't have prediabetes or any kind of glucose pathology.
Yes.
A lot of healthy people who train it are using them. Is that sensible?
Is it sensible? I think, yes. So, what do I mean by that? I mean, some people have insulin resistance, for example, and they're on the verge of sort of prediabetes, and actually seeing what foods affect their glucose levels can be quite powerful in terms of addressing the diet and sort of understanding which foods are more likely to cause these sugar spikes or be more metabolically harmful. So it can give you an understanding. I mean, I don't think it's something you should do forever, but it can be something that is quite educational.
To see what foods impact you.
Do to your blood glucose. I mean, most people won't know what a high or a low blood glucose is. So, so it can also cause a lot of stress and a lot of insecurities, and needs to be perhaps used with some caution with a dietitian or some sort of healthcare professional giving some advice. But it doesn't need to be certainly forever, but it can be useful.
And one thing that's interesting, but picking up on that, without committing you to anything permanent, is there what would you consider a normal range of blood glucose?
I guess, well, when you're fasted, you certainly want blood sugars to be certainly below 7, when you're fasting, probably sort of lower than that, because 7 is already high. And when you eat, obviously after 2 hours, you still want to be into that sort of normal range. But if somebody does spike up quite high, then that's already sort of early evidence that perhaps your pancreas has a level of insulin resistance. And I'm talking without any evidence, because, obviously we use the HbA1c to say whether somebody has pre-diabetes or diabetes or an oral glucose tolerance test. But I think from anecdotal data from patients that do use these, you can see that the ones which have an element of insulin resistance do go up quite high. But then, although they come back within a normal range, that's not a normal physiological response.
Understood.
So yeah, I mean, obviously when you're fasted, you want to be around 4, 5, 6. You're already sort of a little bit high.
So there's more evidence for HbA1c.
Yes.
What would be the range for pre-diabetes and then diabetes on HbA1c levels, just out of interest?
It depends if you're European or American. So in Europe, there are 2 ways of...
Let's go the European one. That'd be the sensible one.
So in percentage terms, 6 to 6.4% is pre-diabetes, or 6.5% and above is diabetes. But the other way that we report this is in millimoles per mole. Yeah. So 43 to 47 is pre-diabetes.
Okay.
And 48 and above is diabetes.
Thank you. No, because a lot of people will be getting blood tests from their GPs and seeing these results and not quite understanding what the numbers mean.
Yeah. I mean, usually they do come with some sort of interpretation of the results, but I think most patients do understand because the GP says, look, you've got prediabetes. What I'd like to stress is that prediabetes is not a healthy state, and it is associated with a high risk of cardiovascular disease, myocardial infarctions and strokes. So whilst most people are like, I don't want to have diabetes, you actually want to reverse your prediabetes status as well. And weight loss, of course, can do that. We know that weight loss can help to reverse a lot of conditions. And if you intervene early in prediabetes and, of course, type 2 diabetes with weight loss, you can reverse these conditions.
I must say that's the thing that really surprised me in the last few years, just reading articles that diabetes is considered certain types of diabetes considered reversible through weight loss.
Yes, correct. And we know that we have visceral fat around the pancreas and the liver, which essentially means that insulin doesn't work well. We call that insulin resistance. But losing that visceral fat, the fat around the organs, can really help to just to revert sort of insulin sensitivity back to normal.
Fascinating. And Kalpana, weight loss isn't just physical. There's huge emotional and psychological components. How do we support patients through mental challenges of losing weight?
Yeah, I think that's a big component around psychology and the social impact on when the patients are obese and go through weight management services. So we have a holistic approach, and in our team, we have a multidisciplinary team to approach the issue. So at the initial consultation, we would take some psychological history of the patients on whether they are suffering from anxiety, depression, which is very common in this group of patients, and whether there are any deep-seated emotional trauma which needs addressing. And we have a psychologist on board who would review all the patients who, especially if they're considering the surgical pathway, they will have a psychology assessment as a part of their package for surgery. But if they're exploring the pharmacological treatment, we do give them an option, because it's very important to address the psychological factors, to set realistic expectations of the weight loss they're going to achieve. And it's not that, if once they lose weight, it's going to be fixing every problem, because these deep-seated psychological problems may still continue despite the weight loss. It does significantly help with the self-esteem of these patients who primarily are in that situation because of the way the weight is stigmatized and there is prejudice. And certainly weight loss does help to improve the psychological state. But if there are some other factors involved, they may not dramatically change. And that's the reason why we have to set realistic expectations and provide them psychological support in the long term. And you asked about the social factors. Again, after losing weight, they may have issues with the relationships, because the patient does require significant support from friends and family when they're going through this weight loss journey, because it is not easy. It's a difficult way to lose weight, and it's perceived as a quick fix or easy way out, whereas actually coming to terms with acknowledging their problems secondary to weight and coming to see us to lose weight does require a lot of courage, and having some support from family and friends is absolutely crucial to support them through this journey. And a lot of times, if that is not in place, they can go through quite a lot of emotional trauma, because they can lose their friends, and sometimes they don't want to disclose if they've lost weight and why they have lost weight. Then that can cause a lot of tension amongst the families.
And then it is really important to help them build positive relationships with food and with their bodies during the process.
Yes, that's true. And that's why we do have a follow-up plan with the dietitians, and if the patient does require any further psychological support, that would be available too, because you would get the best results only if the follow-up care and wraparound care is in place to support the patient through this journey.
Well, it's like me doing an
loss.
ACL reconstruction, the patient having no physio afterwards. It's no point doing the operation.
Yeah.
The rehab and the support is key. So we've talked kind of about the baseline level, psychological components, touched on intermittent fasting, but we're beating around the bush here, really. I mean, the key thing now are the medications that are available. I mean, they appear to be revolutionary. That's my word. But it really, and the first one we heard about was Ozempic, semaglutide. How do you pronounce it?
Semaglutide.
Semaglutide, okay. And then what was it, Wegovy, and now we're hearing more about Mounjaro, which is tirzepatide?
Tirzepatide, yeah.
Yeah. How do these drugs work? You touched on it earlier, and just want to know, how do they work and who are they suitable for?
So the drugs work by mimicking some of these gut hormones that I mentioned earlier. So semaglutide, which is original Ozempic, but Ozempic is for type 2 diabetes, and Wegovy is the higher dose for weight loss. But semaglutide is a GLP-1 analog, so it mimics GLP-1, whereas tirzepatide or Mounjaro is acting on two hormones, so GLP-1 and GIP, which is another one of these gut hormones involved.
Okay. So it's more effective, Mounjaro, because it works in two pathways?
It is more effective. So if we take the highest dose of Mounjaro, which is 15 milligrams, and the average weight loss in the SURMOUNT-1 trial, which was a sort of seminal SURMOUNT trial, was over 22%, compared to around 15% with the top dose of Wegovy. So this is not a head-to-head trial, but yes, I think Mounjaro is more effective than Wegovy. That doesn't mean that everybody has to lose 20% of body weight. So we need to tailor the right treatment to the right patient. Certainly in the elderly, for example, you may want to be a little bit more cautious in the weight loss. So everybody has to be, the care has to be individualized.
And who would be suitable for these medications?
So
there must be criteria, I guess, that you work to.
I mean, broadly, the licensing is a BMI of 30 or a BMI of 27 plus one complication. And that's for most weight loss medications, including Wegovy and Mounjaro. If we're looking at sort of more like NHS provision of care, we're looking at NICE criteria, which is more about a BMI of 35 plus one complication within the NHS. But even within that, it's very, very difficult to access these pharmacotherapies within the NHS.
Yeah.
There's a sort of priority criteria as to who actually has access to them. But within the licensing, pretty much 2/3 of the population in the UK. I mean, we have, very large prevalence of obesity and overweight. And most people who are overweight, a lot of them at least, will probably have a complication of sorts, hypertension, hyperlipidemia, prediabetes, polycystic ovarian syndrome, bit of osteoarthritis, for example.
It's interesting because BMI of 35 is high, isn't it?
BMI, of course, is not the best way to assess obesity, just as a principle, but it's good for the general population. Yes, I mean, in the UK, BMI of 35 plus one complication is about 4 million people in the UK. So it is still a reasonable number of people. But like I said, access is very, very difficult.
Because there's clearly a cost issue with regards to prescribing these medications.
Sure, but I guess we need to look at the cost savings, why we're doing this. And like I said, with one intervention, we are improving so many different diseases. People can come off their insulin treatment. They can come off the CPAP machine. They can go back to work because their osteoarthritis gets better.
Yeah, it must cost hundreds of millions, if not billions, of lost productivity.
I mean, the cost of obesity in the UK, if we look at sort of the total cost to the economy, it's about £98 billion. It's about 4% of GDP. It's huge.
Yeah.
And it's like having this elephant in the room that nobody sees. It's really quite extraordinary. So the costs are very high. We need to recognise it as a disease. The UK government does not recognise it as a disease still.
I didn't know that.
The Royal College of Physicians does.
Yeah.
And of course, many countries in the world and organisations do. So I think that's an important step. But of course, I think the pharmacotherapy is providing the catalyst for change to a system which just hasn't worked.
Yeah, and I guess it can be quite easy to think of the cost just being the cost of the drugs. But if we are talking about support, monitoring, all dietitians, psychologists, then there's a whole industry there.
It's not just a drug. Absolutely right. Obesity is a chronic disease. This is not a sort of short-term intervention. Like bariatric, it's not just about having the bariatric surgery. You still have to do the follow-up after surgery. And it needs to be managed like lots of chronic diseases, like diabetes, for example. But I think intervening early can help to avoid the complications associated with obesity. And currently, we are intervening very, very late.
Yeah. Kalpana, are there any patients, I mean, you're a surgeon, are there patients who you think would benefit more from medications over surgery?
So when I see the patients in my clinic, I mean, nowadays they all want the pharmacological medication. So they've done their research. So for surgery, we follow the NICE guidance in the UK, and that's followed in the NHS, that you have to be a BMI of 35 and over with a comorbidity such as diabetes, hypertension, hyperlipidemia, PCOS, to be eligible for surgery, or a BMI of 40 and above without any of those complications, which is kind of extreme obesity. And I think for that population, patients with that high BMI, surgery is a gold standard treatment, because with surgery, one can achieve 30 to 35% of weight loss over a period of 1 year, compared to the pharmacology, as we mentioned, with semaglutide is about 15%, and up to 20%, 22% with Mounjaro. But when your BMI is so high that to reverse certain complications, you require higher weight loss, and surgery still remains the best option. So when I see the patients, I offer them all the available options, obviously surgical options if they are eligible for surgery. But if they are not eligible, as per the NICE guidance, and the BMI is, say, around the class 1 obesity, which we call between 30 and 35, or 27 and above with a medical condition, then certainly we discuss pharmacological treatment as the best option for that group, if they prefer to go down that route.
Right.
But even if they're eligible for surgery, we still discuss, because all the patients, as you're aware on the social media, are fully aware, and most people are risk averse. So they're concerned about having surgery. There are myths around surgery. So we try and explore and give them a clear understanding about how safe the surgery is, and leave the option for the patient to decide.
And I definitely want to come back to surgery, but I'm not quite ready to let go of pharmacological treatments just yet. Barbara, do you ever get patients? So I appreciate BMI is not the best measure, but that's the measure that's used by NICE. Do you ever get patients with BMI 25 or under asking for these medications?
There are patients that do ask, and there is, I guess, some misuse of these medications in patients who should not have access to them. They certainly won't get it from me. Having said that, we do have to do some adjustments for ethnic populations. So in the Southeast Asian population, we would modify this criteria by 2.5 BMI. So, for example, I said 27 plus one complication. So it could be sort of 24.5 and above in somebody from Southeast Asia, for example.
Right.
So we do take those considerations into account. But like I said, in general, some people are using the medications inappropriately, without a doubt, more for cosmetic reasons rather than for health reasons. But not from the Cleveland Clinic, I hope.
Well, that's one thing that's interesting, learning from you now, both of you, that the complete holistic wraparound care that comes at Cleveland Clinic, because a lot of the bad rap we've been reading about in the newspapers recently have been about online clinics, online pharmacies prescribing them with little checks. I'm assuming that's how, and that's where people could misuse it, and also perhaps then be a risk of regaining the weight as well as complications.
Yeah, I think it is quite worrying, because the one thing that I always say to my patients, for example, is that this is not a 3 months or a 6 months or a 1 year intervention. This is a lifelong intervention. And a lot of people don't understand that. They just think I'm going to take it for 6 months and that's the end of it.
Yeah.
But there are also side effects associated with the medication that need to be clearly explained to patients so that they know how to manage them. Patients need to be supported, like I said, in lifestyle interventions, in their diet, psychological, mental health, lots of different things. And of course, they might have other complications that require further management. So some people with diabetes may be on insulin or other medications that need to be down titrated.
And adjusted, yeah.
Hypertension medications that needs to be down titrated. And so on and so forth. So it does need to be a holistic approach, and having wraparound care is absolutely essential for long-term adherence and just best outcomes.
Because I guess you could blag it and get yourself a 3-6 month course online, but that there's no guarantee that's going to be sustainable.
Yeah, and I think the evidence that we have is that most people that get it online stop. There's very poor adherence. Lots of people stop after sort of 3 months. So there's no doubt that we find the best results if they do have, like I said, wraparound care or a healthcare professional that looks after them or a team that looks after them. And certainly we can provide that at the Cleveland at the outset. We have, like I said, when they come and see us, then there's always, support with dietetics, psychology if necessary, and also digital as well. We do provide or signpost them to digital weight management programs that can be very helpful and provide like an asynchronous support to patients, sort of 24/7. I think that's really important and certainly will change how we deliver healthcare in obesity and lots of other chronic diseases.
And so these are delivered via apps, are they?
Yes, so there's one particular one that I'm involved with. I'm a shareholder. I'm the chief medical officer of Roxanne, which is part of Reset Health. And Roxanne is a digital weight management program that you can download. And it started life with a lifestyle program, in fact, based on intermittent fasting, which does seem to work for many patients, but it doesn't have to be that particular intervention, but it's basically a holistic approach led by medics actually, and enabled by the digital platform itself, which provides with lots of support, whether it's recipes, physical activity advice, psychological support, and so on and so forth.
Because I think Noon was another one that I'd come across. I think there's a few of these now. I don't have any shares in any of these.
Yeah, no. But... So Roxanne is NICE approved. So there's about 7 that have actually been approved by NICE and have gone through rigorous testing. And there is, apps. What do we mean by an app? Sometimes they're not very interactive. You could have an app just to tell you, sort of the steps that you're doing every day. These are actually fully fledged digital weight management services. Rather than just an app, and can really help support patients.
And I think increasingly people are getting used to, using apps and having 24/7 support or access to information, or I guess information that's curated for them.
Absolutely. And, and you can, like I said, lots of people always have questions and they create their own forums. You can see them on online platforms, and a lot of misinformation out there, both about drugs, about surgery. And so it's really important to have access to material which is accurate, correct,
and vetted.
And it's vetted by healthcare professionals.
I really do think that these new kind of pharmacological agents are going to be revolutionary, life-changing for hundreds of thousands, millions of people when the time is right, when the availability is there. There are side effects. There were a bunch of articles in the last week or so. I think 98 deaths have been directly or indirectly attributed to GLP-1 agonists and similar. What are the side effects we need to be aware of? I mean, what are the most common, less serious ones? And then let's work our way up.
So pretty much everybody will experience some sort of nausea. This is well recognized, and that nausea does get better over a period of weeks or months. So, but also gastrointestinal discomfort, constipation, more so than diarrhea or loose bowels. So those are the sort of common side effects. The ones to watch out are, for example, if you lose weight very quickly, which can, of course, happen with a diet or bariatric surgery or pharmacotherapy. So it doesn't seem to be a direct effect of pharmacotherapy, is gallstones, and gallstones can lead to pancreatitis. So this is quite rare, but if patients present with severe abdominal pain, especially radiating through to the back, nausea and vomiting, that is a medical emergency. They should go to A&E. Of course, patients with type 2 diabetes are also more likely to get pancreatitis and gallstones, and it's very difficult to comment on these particular deaths as to whether it was GLP-1 related. There could be very high-risk patients because severe and complex obesity is associated with lots of complications. On the whole, the clinical trial data is relatively safe at this point in time, but it is very sensible to be followed up by a healthcare professional or a team to make sure that the side effects are minimized and managed appropriately.
And are these drugs sustainable for long-term use?
So the answer is that they should be used long-term.
Yeah.
Obviously, the trials that we have probably been no longer than about 4 years, although we have been using GLP-1 agonists for type 2 diabetes for well over 10 years.
Oh, really?
Absolutely. They've been around for a long time. We used to have the daily injectables, liraglutide, if you remember Victoza, Saxenda, then we've now moved on to
I've not heard of any of those.
Okay, well, you're an orthopedic surgeon. No, but I think exenatide was the first one by SSO.
But they weren't in the press in the same way that these
Not
ones
in
we're
the same way
talking
for the treatment of type 2 diabetes. Then, of course, they, one of the, not the side effect, but, people lost weight. And then,
unintended effect.
Then they started doing more studies, increasing the dose and then licensing them for weight loss medications. But we have been using incretin therapy, GLP-1 therapy for well over a decade.
Right. Some people now are talking, probably not endocrinologists, are talking about taking these kind of medications at a low dose long term because of myriad of health benefits of longevity.
Yeah, so the health benefits are certainly well established. For example, with semaglutide, we know that for those patients who've had a heart attack or a stroke, i.e. they have established cardiovascular disease, if they do take semaglutide 2.4 milligrams, there is a 20% reduction of having another event. Cardiovascular event, and that's really important. This is on top of taking the statins. Stroke. Yes, absolutely. Yeah. We're still waiting for the Mounjaro data to come out, but we've got some excellent data on heart failure, for example, where there's definitely improvement in heart failure, both with semaglutide and tirzepatide, and reduction in hospitalizations due to heart failure. If we look at obstructive sleep apnea, again, people come off, their sleep apnea machines because their apnea improves. Osteoarthritis, again, is it the WOMAC scores? And if again, semaglutide has been shown to improve, the pain score in osteoarthritis. So many, many benefits. And now new research is now looking into dementia as a benefit. Now, sometimes we think that these drugs are too good to be true in a sense, and what's going to come out in the future, I don't know. But at this point in time, there are benefits, and whilst we don't have the long-term trials for maintenance, what I tend to do with my patients is get them started, get them titrated up to the maximum tolerated dose, and depending on efficacy as well, and then sort of keep them on the lowest dose that maintains that weight.
That's effective. So you take them right to the maximum dose that they can tolerate, and then bring it down to the dose that lets them maintain their weight, lifestyle, these other factors.
And if they, when you reduce the dose, if they feel hungry again, then you know that they need to go back up to whatever dose they were on.
Interesting. Thank you. Kalpana, I want to ask you about bariatric surgery. What are the most common surgical options you perform for weight loss? Because you hear about gastric banding and a bypass, So could you tell us what the options are surgically?
I'm glad you mentioned gastric banding, because we no longer include that in the armamentarium that we have for bariatric surgery. Number one, because it's not as effective as the other options we have available. And secondly, we are removing more bands than we are putting in.
Right. Because it was the Vogue, wasn't it? 20 years ago, so when I was a lad.
Yes.
So what do we do nowadays?
So nowadays, we have the two main primary index operations are sleeve gastrectomy and a gastric bypass. So sleeve gastrectomy is the most popular operation all over the world. The largest number of operations done are sleeve. And what we do in a sleeve gastrectomy, both these operations are keyhole operations. They are very safe, and the patients only require overnight stay. They do require general anesthetic, and they're keyhole operations. So in sleeve gastrectomy, we basically making the stomach smaller by removing about 80% of the stomach by using a series of staples across, and that stomach which is disconnected, the 80% of stomach is then removed from one of the little cuts
from the portals,
from the port. removed and discarded or sent to the lab if necessary. So what
and then
it
you
does,
join the what's left end.
it's staples and
Yeah.
cuts. So both the ends are sealed, the specimen side and what's left behind. So it's just like a very long, narrow tube. It's also called a banana sleeve because
Gotcha.
it looks like the shape of a banana.
Thank you for explaining that. Now I can visualize it. Yeah.
So it's just the new stomach. The capacity is about 100 to 150 ml or
So
less.
you've got a bag, you've got a tube down the middle,
That's
essentially,
right.
and the bits on the side are removed, taken away, closed off.
Just on the side. So we are
on the side,
working along the greater curvature. So we are leaving the inner side as it is,
Gotcha.
and the outer bulging portion of the stomach, 80% of it is sort of removed by using a series of stapling instruments which seal and cut. And we usually have a bougie, or what we call an orogastric tube, which the anesthetist puts down to where the stomach ends and joins, where the stomach ends and joins the first part of the intestine, called the duodenum. There is a valve, sort of a muscular sphincter called the pylorus. So this operation works by obviously restricting the size of the stomach, so you can't eat much,
and then you feel full.
You can feel full much quicker, and removing that excess stomach, which what we call the top of the stomach is called the fundus of the stomach, which is removed, is responsible for production of the ghrelin hormone, which is the hunger hormone.
Yeah, the greedy hormone.
That's right.
Ghrelin, I just remember GR, ghrelin, GR, greedy. Yeah.
So the appetite drops significantly, and that's how the patients are. It's not that they're just not able to eat; they just don't feel hungry. And that's how it helps with the weight loss. And then we have a gastric bypass surgery, which the traditional bypass is what we call the Roux-en-Y gastric bypass, where we disconnect the top end of the stomach. So there is only very little stomach where the food can go into. But by disconnecting it, we are disconnecting the way the food normally would travel down the stomach into the intestine. So we need to create a new route for the food to go down. So we bring a segment of intestine up to this new stomach. So it bypasses its natural, normal route and goes straight down into the intestine from this small pouch. And again, this works by restricting how much a person can eat. But the more powerful mechanism is by stimulating the hormones which cause satiety. It's the peptide YY and the GLP-1 hormone as the food stimulates the intestine. So it's the natural GLP-1 hormones, the endogenous hormone, which help with patient feeling full and increases the satiety. So and helps with the weight loss.
And what's the capacity of the room of the bypass?
So the capacity of the small stomach, which is sort of literally the size of a golf ball or less, again 100 ml or less. So it's a really small stomach. But one has to remember, I always tell my patients that the stomach is a muscle. It's not like a rigid pipe. So over a period of time, it has a capacity to stretch. So it's very important that they follow the lifestyle changes to maintain the weight loss over a long period of time, because the capacity of the stomach to take in more food is going to increase over a period of time. And there is going to be some weight regain in years to follow. And if they're not careful and don't follow the dietary and lifestyle advice, they're at a risk of significant weight regain. So it's very, very important that it works in conjunction with diet and exercise. So surgery by itself is just a tool. Ultimately, it's the lifestyle and behavioral changes that the patients have to commit to for life.
How do you help patients decide between those two operations?
We discuss both the operations. A majority of patients would have done a lot of research. They know exactly what they want. And often, if they feel very strongly about a particular operation, if there's no reason for not offering that, then, we go with patient choice. But in certain cases, one operation may be more suitable than the other. For example, in a sleeve, patients who have terrible acid reflux, we do an endoscopy, and if we find there is evidence of damage secondary to the acid irritation at the lower end of the food pipe, which is called esophagitis, then we do recommend them to consider having a bypass, because often sleeve being a long, narrow tube, there can be a risk of worsening of acid reflux symptoms.
Yeah.
So we do consider that. And there's a condition called Barrett's, where the damage caused by chronic exposure of acid to the lower end of the gullet causes in the esophagus, causes changes of the lining of the esophagus, and if a patient has already got that damage or change in the lining, it's much better. Actually, it's contraindicated to do a sleeve, because they would be at a higher risk of developing something nasty if there is constant acid exposure or worsening acid exposure when they have an underlying Barrett's. So that's particularly a situation where a sleeve should be avoided. And gastric bypass is very good, because there is, particularly in patients with acid reflux, because the stomach size is small, so it would obviously produce less acid. And the emptying, there is no sphincter, it's just directly joins into the intestine. So it's a low pressure system. So the food empties much quicker and elevates the reflux symptoms often. And conditions where we avoid gastric bypass is patients who have inflammatory bowel conditions like Crohn's or ulcerative colitis. It's not a total contraindication, but we do discuss them that, it might be reasonable to consider a sleeve in that situation. And again, I think the most important thing is patients who have diabetes. I think we've seen that in a number of studies that gastric bypass surgery is much more powerful in terms of maintaining or reversing the diabetes and keeping it off over a very long period. Though sleeve has extremely good results on reversal of diabetes, and the weight loss is comparable whether you do a sleeve or a bypass, but long-term studies have shown better control of diabetes with a gastric bypass.
Thank you. That's really helpful. I understand it now. I want to talk about stigma. You mentioned it earlier. Stigma is really, weight bias is a huge problem in society, even in healthcare. And I think there's a lot of people, be it medications or bariatric surgery, are nervous about telling people about it. Some people consider it the easy way out, perhaps. How do we help people through this stigma?
That's a really good question. There's lots of stigma everywhere, and I know lots of people who are taking the medication are even too embarrassed to tell their friends that they're taking medication, for example. But just generally, people just feel guilty about that. They're made to feel guilty, and I think it's because of lack of education, lack of understanding obesity as a chronic disease, and we have a lot of work to do to change that narrative, and to change the narrative that you need to eat less and move more. So, like I said, it's present everywhere. It takes, studies suggest it takes about 9 years for people to even bring up the subject of weight with their GP. But even healthcare professionals have bias and stigma, and again, nobody was taught about obesity in medical school, for example, and so we need just to change that and ensure that this elephant in the room is being addressed in a sense, and people know about it. Yeah, but it's a real issue. Yeah.
I mean, there's a real societal challenge, isn't there? I think that we need to, in terms of, we need to do better in terms of how we talk about weight management, weight loss. The thing that's interesting about it is that if you're type 1 diabetic, you take insulin. If you've got high blood pressure, you will take medication. You've got high cholesterol, you take a statin. No one will question you. No one would worry about saying that. But you're overweight, which puts you at risk of all of these things and more. You don't want to tell people you're taking Mounjaro because it's still stigmatized.
Absolutely. You're absolutely right. So it's how do we change that? How do we change that mindset? I think it will take time, but I think people are doing it, actually. And there are many, there are nearly 1 million people taking these medications in the UK right now. So people are actually just doing it because it works, because we now have agents that work and are safe. But yeah, I think we've still got quite a long way to go but hopefully we'll get there.
Hopefully podcasts like this will help change the
I
conversation.
hope so, very much.
Are there any new treatments or breakthroughs on the horizon? Because you've talked about liraglutide, which I don't know about, and then semaglutide and tirzepatide. So is there anything on the horizon in the field of weight management that excites you?
Yes. There is the next one's called retatrutide, which is totally unpronounceable.
Yeah.
And retatrutide is what we call a triple G hormone. So it acts on 3 hormones, so GLP-1 and GIP and glucagon. And the results are even more impressive. So the mean weight loss in the phase 2 clinical trials is around 24%, but actually women do much better than men, 29% versus 22% as a mean weight loss. And
over a year.
Just over a year. Yeah. And there are significant number that really sort of achieve over 30% weight loss. So we're pretty much in bariatric surgical territory with these new medications. So I think that's quite exciting. And then we're looking at combination therapies. So GLP-1s with cagrilintide, which is an amylin analog, another one of these hormones, again, has reported with an average weight loss of about just 23%. But I think combination therapies will be the new future. And I guess the only other category that's out there is, we do worry about lean muscle mass loss with these medications because the weight loss is so significant. And so there is another sort of group of agents trying to essentially get the weight loss but protect the lean muscle mass, so increase lean muscle mass. And these agents work on the cancer pathways because, with cancer, we become very cachectic, we lose muscle mass. So if we can try and reverse those pathways, that's how sort of the science is trying to address new molecules to do that as well.
Got you. So a lot of stuff on the horizon. Yeah. And I guess for the people taking these GLP-1 agonists right now, maintaining muscle mass is absolutely key. So exercise and strength training. Yeah,
physical activity, resistance exercise is really important. Plenty of protein in the diet. So, we can't make protein, we need protein. And so prioritizing protein and obviously vegetables in the diet over carbohydrates, very important. But, the message is to stay healthy, have a healthy diet, use the medications as a tool. And physical activity, of course, or whatever physical activity they can do. Yeah. It doesn't have to be crazy stuff,
For sure. And in the field of bariatric surgery, are there any things on the horizon?
I think there are several operations which are being done in other parts of the world, but we follow the guidance from the British Obesity Surgical Society and do the operations which are endorsed by the society. So I don't think there is, and that's why we basically stuck to the sleeve and the gastric bypass, because there are more malabsorptive operations which do cause nutritional deficiencies and problems over long term, which are endorsed by the society but done in small numbers. So I think for now, I think these operations have proved the test of time, and they are extremely powerful. And all the new operations which they've been doing in the other parts of the world have not shown any added or advantage. So at the moment, we're going to continue with the sleeve and the bypass. And there is a third operation in addition to the malabsorptive operations is called one anastomosis gastric bypass, where there is one joint of gastric bypass compared to there are 2 joints in the standard old-fashioned Roux-en-Y gastric bypass. But the effects on weight loss are marginally better, which have been shown in a number of studies. But at the moment, I think they're still most powerful despite all the pharmacological treatment. And I think the future, as Barbara mentioned, is going to be a combination treatment because, it's not one size fits all approach. We have to have a personalized approach for treatment because every individual is different. And hopefully we'll have more AI tools in future to be able to risk stratify on, which operation or which treatment is suitable for, a particular patient. Because at the moment, we're not quite there. We don't know which patients are going to respond very well. It's same for pharmacology. If there are certain non-responders, a majority of patients have a good result, and that's why we're offering the treatment. But it would be nice to know if a patient is going to have a suboptimal response,
Yeah,
and whether we
and
could
pick your
tackle that a bit differently.
Yeah.
So
You want
hopefully
to
there will
pick
be
the
more.
winners.
Yes.
Yeah.
I just wanted to add something to Kalpana, because there are also endoscopic procedures that are being done, and we're also doing them at the Cleveland, which are sort of weight loss procedures. They're definitely newer than the
That's
bariatric
correct.
surgery that has been established for a very long time, but they're trying to reproduce, for example, the sleeve gastrectomy. There's an endoscopic sleeve gastrectomy, which is done endoscopically,
Right.
and other endoscopic procedures which form part of the armamentarium and are also offered where we are. So just to add that.
So we are a multidisciplinary team. So it obviously includes our gastroenterologists who lead on the endoscopic procedures. As bariatric surgeon, I'd be offering bariatric surgery, and I think we do offer pharmacological options when patients come and see any of us, really, whether it be a surgeon or a physician. And we have our dietitians and psychologists to provide
It's a whole
added
team.
support.
Thank you. Listen, thank you both for such an insightful discussion. As we wrap up this episode, what's one piece of advice you'd give to someone who is listening or watching, who's been struggling with their weight and doesn't know where to start? What advice would you give for that first step?
Go and get some help. Don't be embarrassed. Don't be stigmatized. Obesity is a chronic disease. And really go and seek the help that you deserve, because your health is important.
I totally agree. I think there should be no shame involved. You don't need to be a health professional to be working towards raising awareness of obesity and aiming to end the stigma associated with obesity. And we should be empowering our patients to speak up. I'm a great advocate for a patient support group and patient advocates to be able to speak up and raise their concerns and seek help from qualified health professionals rather than sourcing any medication or treatment from sources which are unregulated. So I think it's extremely important to hand the power back to our patients to be able to seek help.
That's a great way to end it. So you've been listening to Exploring Health with Cleveland Clinic London. I'm Kash Akhtar. Thank you very much to Barbara and Kalpana for joining us on today's episode. To learn more about weight management and treatment options, head over to the Cleveland Clinic London website. If you found this conversation valuable, then please don't forget to subscribe, leave a review, and share it with someone who you think might benefit. Thank you very much. See you next time.